Hello and welcome to the Federal webinar. I'm Srinivasan. First week of June has witnessed a rapid rise in the number of COVID cases in India. The biggest spike has come from Maharashtra, followed by Kerala. Single-day COVID tally all over India has shot up by 40% on June 9, resulting in daily positivity rate crossing 2% after 111 days. Now, this has caused fresh concerns and raises a question, are we now heading for a fourth wave? While virologists, scientists, and doctors wait for more information, the obvious question is, why COVID cases are rising in India? Is it because we have let our guard down, abandoned social distancing norms, and almost stopped wearing masks? Do we need to speed up the vaccination drive? The cumulative vaccination as of June 7 stands at 1.95 billion doses, with 64% fully vaccinated and 73% of population having received at least one dose. We all now know that COVID is very much around us. It hasn't gone anywhere. We just have to learn to live with it. Now, to discuss this, we have put together a panel of experts. The format is very simple. We start with each speaker speaking for about 2-3 minutes on the topic, after which we open up for discussion. Now, let me introduce the guest. I have with me Dr. Ishwar Gilada. He is the President, AIDS Society of India. More importantly, he is an expert on infectious diseases. He joins us from Mumbai. I have Professor Ranga Reddy Bari. He is President of Infection Control Academy of India. He is based out of Hyderabad. We are joined by Dr. Anusha Rohit. She is the head of microbiology and chair infection control, the Madras Medical Mission based in Chennai. Finally, we have Dr. Sunila Garg. She is member of Lancet Commission COVID India Task Force and professor at MAMC Delhi. She is a global specialist in community medicine. I welcome all of you, and let's now hear one by one. Dr. Reddy, what is your take on this? Where we are now, and what should we be doing?
First of all, thank you very much for having me on your show, Mr. Srinivasan. As you very rightly said, COVID is not gone anywhere. It is just lurking around us. There are a lot of different ways how this pandemic can pan around. If you look at the kind of projections and the predictions, some of them coming from IITs, IIMs, etc., we keep hearing that in June there would be a surge, or they call it as wave, or probably July or August, we'll have another wave, or the next wave is going to last for another 6 months, etc. Whatever are those predictions or the scenarios, it is abundantly clear by now that all possible scenarios which we are assuming are going to bring us into a stable position only eventually, probably over a period of a few years. It is not going to be days, months, or weeks. Okay, that is one. And one significant factor which is going to disturb us is going to be definitely an emergence of new variants. But having said all these things, it doesn't look like that we will see a huge surge like what we have seen with earlier variants, especially the Delta variant, because the population defenses against the COVID, I think, is increasing. The seropositivity is increasing. The vaccination has been, as you very rightly mentioned, to a very large population. So I think the plausible scenario would be that we will slowly move into an endemic state where we would see possibly the surges happening in certain pockets of the country. Maybe a few districts or few states probably would see the surge. But I think we need to learn to live with those kind of outbreaks which are going to happen at a local or regional level. Probably, that is what is my take for now. I think more as we move on.
Yeah. Dr. Sunila Garg, how would you look at it?
First of all, Srinivasan, thank you for having me on the show. And as has been, the stage has been set very right by Dr. Rangareddy. What I will like to say as a public health expert is that if we look at, public health experts, they rely on the situation, with regard to number of cases, the test positivity and all that. But if I look at number of cases from 26 May in Mumbai itself, we started with 295 cases. And on 8th of June, we had 1765 cases. That means nearly 65% rise in cases. And, similarly, the testing positivity rate was around, 9%, but hospitalization was less than 1%. And if we look at Delhi, the COVID progression rate was, from 26 May, 403 cases to we rose to 564. But again, Delhi testing positivity rate was much lesser as compared to Mumbai, which was 9%. I told you it is about 2.13%. And also, we need to see that, total number of cases, which we are looking at, the average cases have risen from 5,233 to 7,240 Delhi cases I'm talking about, everyday cases which are there at the national level. And then the testing positivity rate has gone in last 3 days from 1.21% to 1.67% to 2.13%. So this is the testing positivity rate. But if you really pointed out earlier, as we were discussing, that we have to look at, the state-wise progression of the pandemic, or now what we call it as it is progressing towards endemicity. But then we have highest number of cumulative cases in Mizoram, followed by Kerala, followed by Lakshadweep, followed by Delhi and Maharashtra. Like that way we have got, varying from 1,91,696 to, Maharashtra has got cumulative cases 64,663. But you see, if we look at COVID cases per million, if I was to look at the recent data, there the Kerala tops the list in terms of 65 cases. But if we look at an overall situation, as has been pointed out, looking at the number of cases which, are, spread across different states in the country, 36 states and union territories, the pandemic is in, or I'll say the disease is in different stages of progression. So we have to view this disease state-wise because India is very different. We have rural, urban, peri-urban, and, metros where, we are mainly, the testing is being done across those areas. And also we need to look at our, genomic sequencing. The 30th May data, which was released from across, 5 countries, which included India as well, all cases have been of Omicron variant. So that is another thing which we have to keep in mind. But also, which was pointed out earlier also, this is a transmissible virus. It may highly transmissible. It may not cause much of hospitalization and all, but probably, we have got, over, substantial number of cases which have been vaccinated. But then we also have to see that how many of us have received the precautionary dose. Over a period of time, there has been laxity in terms of, if I was to look at last 4 or 5 days, the cases, the people who have been vaccinated are even less than 2 lakhs across the country. So that is where we need to look at even our vaccination status. And there is also need to relook at the vaccination as of now. This is what is I like to say at this point of time. And as we move further, we will debate on it further, but definitely compromise is there at all levels, whether we talk of COVID appropriate behavior in terms of masking, in terms of social distancing, in terms of, sanitization and all. But, we have to also see the developmental issues at the same time, keeping in mind the pandemic scenario into picture. Thank you.
Right. Thank you very much. Dr. Gilada.
Thank you very much, Mr. Srinivasan, for having me on the show among the galaxy of people. What I would like to assert is that India has been following organizations like WHO, where narratives are very poor. India being number 2 in population will be number 1, number 2, number 3 in many of the diseases, infections, problems. So when we should talk about narrative, we should talk about per million population. If you look at number of cases cumulatively, all in 2.5 years, India is at 157th rank in 215 countries, number of cases per million population. in number of deaths per million population, it is at 139th rank. So that is number one in general. Number two, I have been saying for last couple of months, maybe 6 months or so, that this variant, Omicron, is a variant of support rather than variant of concern. Now, variant of support means, like in our body, we have common cells. They help us to a lot of things. And if we give some antibiotic to get rid of some infection, common cells also goes away and we create problem for ourselves. Now, in Omicron, what is happening currently, it is, don't go by numbers. Because these are kind of knee-jerkism. The number goes up, people start masking, and people start talking about vaccination. Vaccination should be best done when the numbers are low, whether for this infection or any infection. Because when it's peaking and that time you increase vaccination, you don't know whether you are vaccinating a person who is already incubating the virus or already having the infection. So that is counterproductive when you are doing vaccination during the peak of the pandemic. So let us not talk about vaccination now. Whatever has to be done should be done. But what I would like to say, that go by trajectory of infection. If out of number of cases, how many are requiring oxygen? Hardly 2-3%. Out of how many require bed? Sunila Madam told 1%. What is the death rate or case fatality rate? 0.1%, which is as good as flu. So if we are not bothered about flu, why should we be bothered about the COVID flu? COVID is also a flu, basically. So I think we should look at trajectory. And when we don't look at trajectory, what happened? When the Kerala cases were surging, whole country came on hounding on Kerala. Did Kerala beg anyone that we need kits, we need this, we need ICU? They didn't beg anyone. They managed on their own. So when they are managing on their own, the case fatality rate cumulatively remained at 0.5%. Kerala, Maharashtra have been honest in reporting. So go by that aspect. Don't go by some states are not reporting, so they are managing very well because death rate is low. And lastly, really what deaths we are seeing, there are readjustment of deaths happened in the past. So whatever deaths you are said today, there are 24 deaths, out of which 17 are past deaths. So nationally, we have only 7 deaths. Weekly, we have somewhere around 10 to 11 deaths per week. I don't say that we should allow these 10, 11 people to die, but we have to analyze who are dying with a comorbidity 60 plus. So if comorbidity people are dying, then your vaccination strategy, you have made people to take free vaccine all along 2.5 years. Now suddenly you're saying that below 60 you should pay. There is no option for them to take vaccine from somewhere. We have 20 crore vaccine lying idle. It is going to expire by July 8. And we will allow vaccine to expire, but we will not provide the free. So I think we have too many committees. Even DCGI approves a vaccine, Netagi sits on it for 3-4 months. They don't give a clearance. Why should we have so many committees? If they don't understand pandemic, if they are not having an honor for DCGI, abandon DCGI, only keep Netagi. So the DCGI has given clearance to 9 or 10 vaccines. Where are they? You go to a restaurant, you ask for something, they say, no, ye menu mein hai, lekin yahan pe nahi hai. So whenever you ask something, that is not there. So just giving a license, and when utilization is 99% by one authority, Government of India, then there is no use of giving license, and Netagi sits on it and not allowing that vaccine to be used. So I think we should look at a lot of issues. I think over the next 1.5 hours will come over. But I have this kind of very clear issues that India should not be in a knee-jerkism. India should not blindly follow WHO or international agencies. We should have our own narratives. We should honor our own people. And lastly, we medical people, we never talk about any bridge, any river, anything. Why should IIT people talk about pandemic? Some of the IITians have given a date. 21st June, there will be 4th wave. Is this not a horoscope? What are you talking? And this same IITians under Sutra model, which is called National COVID Projection Council, and they said Government of India sponsored body, and they said there is not going to be second wave. We have seen what has happened in the second wave. Government of India sat on it. They thought that what our body is saying is right, and we were caught unawares. Now same body on different people, same people in different bodies, they are talking the same thing. So I think we should not give any credence to. They are good for grabbing headlines. Anyway, anytime in newspaper also, a dog biting man is not a news. A man biting dog is a news. And therefore, when they give a particular headline on 21st June, we'll have a fourth wave, whether it comes or not, but they got the headline, but they will say, no, things have changed, people behaved, we've seen masking, we've seen vaccination. So they will say all sorts of things when there is no wave on 21st of June. Thank you.
Right. Thank you. Thank you for your opening remarks. We'll discuss more. Obviously, you opened up the debate, a lot of new issues. So we'll discuss all those. Now, I come finally to our fourth guest, Dr. Anusha Rohit. What's your take? I would like you to also include, Dr. Rohit, that, WHO scientist, chief scientist Soumya Vishwanathan has said that BA4, BA5, Omicron subvariants are making their presence felt. And this could be a start of mini wave. I mean, I'm not saying wave in the sense of what you see in newspaper headlines. What Dr. Ishwar Girida was right now saying that, India is a very diverse country and you have to look at differently and don't go for these aggregate numbers blindly or these daily numbers blindly.
Thank you, Mr. Srinivasan, and good evening to the panelists. At the outset, I would like to set the stage by saying about the three scenarios that WHO has envisioned for the way the pandemic is going forward. The first scenario is a base case scenario, is that what we are seeing right now is that there will be a slight increase in the number of cases, but it will be not too severe because of the immunity and the general factors that are there within the community. The second is a best case scenario, because we always like to talk about the good first. The best case scenario is where we will have the virus getting even more subdued to just be a virus that is circulating within the population, but not really causing any havoc that we are anticipating. And the worst case scenario, if we were to face one, that would be probably a deeper sense in which you have variants of concern coming up like the Delta that came up and causing and wreaking havoc amongst countries. Now, I think at the outset, what we have to look at in the country itself is that, yes, there are a slight number of increase in the number of cases, but that does not explain or give us any need to panic and worry about the fact that we are going in for a next lockdown, or are we going in for the next, we saw how China was again going back into, quite a lot of frenzy. I don't think we're going into that case. So what we need to do is look at the data. Most of the cases, yes, there have been slight increase after a long period of lull. We had, a few number of cases that have come up in the recent past, but many of them are asymptomatic, none of them requiring admission. But we have to understand that when there is a patient who has a comorbidity, like, for example, who's requiring, say, a heart ailment that needs to be addressed and is also COVID positive. So how are we going to deal with these cases? Now, these are the scenarios that we need to actually look at from a practical point of view for the country without really getting too, worried about things. But at the same time, I would like to also emphasize that after the Omicron, I think literally, yes, Omicron was a very good strain in terms of inoculating the population and getting us all a little immune. But on the other hand, it reduced the fear and the need for vaccination amongst many people in the population. So many people have not really taken their precautionary dose. They're very happy with the first and second dose. But as you know, Israel went for even the fourth dose. And following that, I don't even know if they've had more doses coming up, because we just lost count of the number of boosters that they actually took. So considering all of that, I think we need to have, for a country as vast and diverse as India, a very, very scientific based stand based on the data that is coming in, real-time data and surveillance data from, for example, the surveillance of the sewages to see for baseline activity of the virus. So with those words, I think we will carry on with the discussion.
Okay, thank you very much. I think now the ground is set by these opening remarks, but I'll go one by one. Let's now first take some of the more important issues. I'll again go to Dr. Rohit to ask this question. Dr. Anusha, we know that as time passes, the way new variants have to be much more sturdy. That's when it will survive, and maybe it has to be more infectious also. Virologists say that it can only survive when it is more infectious, and it has to be better than the previous one. Otherwise, it won't survive. Therefore, we have to constantly look out for this new variant. Isn't that makes the fight much more difficult? Because, like Dr. Grada was saying, it is, I really don't know what his views on how should we go about testing. But I would like you to answer this question: that how do you deal with situation when we know that yes, we are possibly in the three scenarios you described. Right now, we are in a better scenario, but then can we lower our guard? Because whatever come next, if there is a variant which is going to come, is not going to be easy to deal with.
Right. Thank you for that question. So if you look at the whole concept of the way the variants survive, or for that matter, any microorganism, the will to survive and the Darwinian way of survival is when you can have increased transmissibility, but not so much of mortality. If you look at, for example, SARS-CoV-1, it was not something that, because the mortality rate was so much higher, it was not something that survived and really spread across the whole mankind like SARS-CoV-2. So I would think that, yes, we need to, to answer in short your question, yes, we need to constantly be on the lookout. Surveillance is something that we cannot get complacent about. But at the same time, I think we need to understand that there's no need to panic. We need to be constantly under vigil, but that's not going to be enough for us to panic and say that every new variant that comes is going to be more virulent than the previous one. So, for example, the Omicron variant came after the Delta variant, but turned out to be not that bad as the Delta. So the prediction models, of course, can be mathematically modeled, but nonetheless, what happens in nature is something that we have to see. I don't think a prediction model really works with nature. So with those two thoughts of mine, I'd like to pass the question on to anyone.
Yeah. So, Dr. Reddy, I would like to come to you as a infections specialist. What would you recommend now? Should we be going for what should be the protocol to be followed? Earlier, we said test, and more test, and then isolate, and then treat. What should be the approach now?
I think the approach had to move from individuals into more general, that is at a public health level, at a population level, right? So we need to constantly work on our surveillance, which is the major part. Testing and tracing probably, is impossible in this kind of scenario. Initially, when the disease has started, when you wanted to actually break the chain, it was possible, to do it was required probably to do the tracing, etc., etc. But today, I think, it is more of at a population level kind of surveillance which had to go on. It could be sewer surveillance, that is sewerage, take constantly the sample and see, what is happening, what kind of, are there, any new variants coming, or you have got any subvariants actually lurking around. That is one thing, what we had to look at. Second is protecting the vulnerable population, targeting to save every one of, let's say, 140 crore is going to be a very expensive and also futile way of doing the things, because 90% of the population are not vulnerable today. That is very clear, right? So what our government and also, other authorities actually, a role should be identifying that vulnerable population and take steps in order to protect that vulnerable population. Who are they? It is abundantly clear. That is elderly people, the people with comorbidities, the people with immune deficiency, etc., etc. that is the second part of it. The third part of it is whatever learnings we had from the COVID-19 first and second wave, especially. Third wave actually did not give much of lessons for us. But the first and second, I think, it has given a lot of lessons in terms of our infrastructure ramp up and also identifying those vulnerabilities within our healthcare system. They had to be plugged and necessary investments had to go in there. I think, that is the third part. Fourth part is, I think, from the first, second, and third wave, one silver lining is that we had a lot of innovations happening. Some of them are incremental innovations. Some of them are very radical innovations, in terms of actually managing these kind of outbreaks, epidemics, or pandemics. Those had to be brought into the mainstream now in order to prepare our nation for, God forbid, if we are going to have the next one or we are going to have the next variant, to be prepared actually for that and effectively manage, because they are two different components. Preparing is one component, and acting, when the incident is going to happen, they are two different things. So, we need to involve all these innovations which have happened during this period, effectively translate them into, daily objects for, the healthcare system, so that, we can deal with that effectively. Fifth thing, what I would like to say is, like Dr. Gilada has very rightly mentioned, the knee-jerk reactions are not required. Just because, there is an outbreak somewhere, and from one case, it has increased to 10 cases, we suddenly, start acting in a very fuzzy way. That is not going to yield, much other than creating the panic and unnecessary actions, which is going to consume otherwise already, kind of stressed resources we are going to deploy in a very wrong way. So that's why these knee-jerk reactions should not be there. The local administrations and local kind of system had to be geared up by training them so that there is no knee-jerk reaction, but a very planned, systematic kind of reaction in order to deal with the outbreaks. Probably, that is what is my take to your question.
Yeah, thank you. Dr. Garg, now I come to you. Dr. Reddy pointed a very important point that now we need to move from this earlier mechanism. I think they already moved, that we have to look at community as a whole. We need to do zero surveillance and also SIVR and other things which he suggested, rather than focus on communities now. And since you are an expert dealing with community medicine, and what should be the communication to the masses? How should they be cooperating in this? Because a whole lot of things also depends on how people respond to this.
Yeah, thank you so much for this question. First of all, one of the important things is that we need to look at the system as a whole, because you cannot isolate the communities. So when, it was pointed out that we need to look at the capacity building is not only of the institutions, but also of the communities. So that means they need to come forward and cooperate. Any program is going to be successful when your communities are empowered. That means, when we talk of the vaccination, though it is not a knee-jerk reaction, but the time is there that this is the time when, our manpower sufficiently can take care of the vaccination part, particularly the precautionary dose. But when it comes to children, I will definitely say that there is no compromise between the school going and the vaccination. That is another important thing, because you cannot compromise development versus the development versus the vaccination part. And another thing is that, in children, we have to remember that the infection is milder, it will go away fast. But then, think what has to be, taken care at home settings is when these children come back to home, unless they are elderlies, who are sick, who are comorbid, generally that is the scenario. So they need to take precautions. That is important. So community needs to be empowered with regard to COVID appropriate behavior. And I think countries like Japan have, gone ahead with the, permanent masking also. So that is, I feel, to my mind, that can also be a solution, because you see, if you see the northern part of the country, we have more people suffering from chronic obstructive pulmonary diseases and all that. And during the month of October, November and all that, so many hospitalizations are there because of pollution as well. So that is another important part which we need to keep in mind. Another thing is that when we talk about the surveillance part, which has been mentioned, our IDSP platform is very strong. So this is where the link comes between, our healthcare workers or the grassroots level, I'll say frontline workers, who are Ashas and Anganwadi workers, not MPWs, they're healthcare workers. So they have to, feed in the data regularly with the help of our healthcare workers, so that the data gets fed into the IDSP platform. And at a national level, we get the complete picture of sitting in Delhi or sitting in Mumbai, what is happening, in different states. So that is another important part which we have to keep in mind. But then, testing definitely will give us the picture, exactly how we are going to go ahead with that. And, we need to, also empower people that if there are symptoms, promptly isolate themselves. That is also important part. And this message also has to go to the different authorities, whether we talk of the school settings, whether we talk of the organizational settings, both, the government or non-government organization settings. Let people isolate themselves if they are there. So that is where, we need to take care of the system as a whole. So that will be another important thing. And what we observed during this pandemic was that majority of the services have been affected. So this is where the role of capacity building comes in. Our, sustainable development goals have gone, many years behind, particularly to take care of tuberculosis, or we talk of, the different infections which were not addressed. And even for a simple thing like normal delivery, people were running from pillar to post. So this is where, the pandemics will come and go, but our systems need to be prepared. So we need to move in that direction as well.
So sorry, I'm interjecting you. I mean, I'm happy that you referred to ASHA workers, and you also talked about capacity building. Dr. Garg, India has 1 million ASHA workers, and they recently won global recognition. They got accolades all over. And, all of public health workers all these years, especially after pandemic, have been calling for better facilities for these workers as a part of overall capacity building. Has it actually happened? They were a kind of backbone, at least, in some aspect, they did play a crucial role. Vaccination or pre-vaccination detecting. Has anything substantial happened in the direction? If you are aware of it, can you tell us?
No, this is a very crucial thing which you have pointed out. Particularly, you see, when we go to the field settings, it's not only the pandemic times. Any program that is always, loaded onto ASHAs, that is there. So we need to take care that we earlier, I am going to talk of 82, 83 and all. We never had any ASHAs. I'm talking of my days in public health when I began. There were only MPWs because they are the regular paid people, So we need to kind of shuffle the responsibilities and we need to redistribute. Everything cannot be done by ASHA. She is responsible for running virtually every implementation of every program. So I think the message should go from this platform very, very carefully that ASHA needs to do the work for what she is meant. And we need to create a set of manpower which will facilitate. When we talk of testing part, when we talk of isolation part, or when we talk of different issues related to pandemic, we definitely need to create, manpower depending upon the situation where we are. If we are, when we prepared the guidelines for rural, peri-urban, tribal, we brought in the role of, even the volunteers in those settings, because you see, ASHA has got lot of programs which is already doing, whether you talk of RCH program, TB program, non-communicable disease program, Rashtriya Bal Swasthya Karyakram, Rashtriya, Kishore Swasthya Karyakram, everywhere ASHA is involved. And if I want to do a program, I will look forward towards ASHA. So I feel that the conditions need to be really made, manageable for ASHA, so that, this was a pandemic time. So you could see that most of the services were compromised because ASHA was not able to do the job. Subsequently, we realized that, okay, we can utilize this platform for, giving the supplementary nutrition as well, because we could see the increase in number of malnutrition cases also. And this is where we need to have a very, very holistic approach. not a knee-jerk reaction, and not to work unipurposely. We have to work multi-purposely, involving many people who are there. And we see that, there is a multi-purpose worker whom we call it as female, we call it as, A&M, or, there's a male multi-purpose worker comparatively who is an underutilized worker. So we need to look at the redistribution also. And now under Ayushman Bharat, we have got community health officers, and where telemedicine has got a very, very critical role to play. So under Ayushman Bharat, we have got 1,17,000, health and wellness centers which are functional. But the time is there that how to reach to the communities through healthcare, these health and wellness centers by empowering the people with the necessary skills. So here comes the linkages with the district hospitals. And already we were discussing before, we started this program, that there is a differential performance in different states. When I talk about hesitancy and all with regard to vaccination in different states, in southern states, they have done fairly well. And they are also, eSanjeevani platform is very, very functional. I talk to each and every, community health officer in those states, who are working in health and wellness centers. Every day they are having, this, they're there on the platform of eSanjeevani. And so we need to look at, how we empower every state in terms of, so that there is optimum utilization of manpower, so that no program is compromised. We have to work horizontally rather than working vertically.
Right. Yeah. Thank you. Now, I want to come to Dr. Gilada. You mentioned a point, and I tend to agree with this. You see, mathematical modeling is not like psephology. Even psephology most of the time goes wrong. We have found out. I mean, it's, I do agree that there is interdisciplinary. Maybe it also, but whatever the modeling is done also would depend on the quality of data. But would you agree to at least one issue, that it is important to be ready that we have some kind of projection? Long-term projection may completely go off wrong, possibly, but at least we need to have some kind of understanding of this, and therefore some kind of projection, because it may help in vaccine sequencing. Probably, you would know whether immunity levels are enough in the community, so that how much vaccination need to be done. Also, if there is one view that if you inject too much of pathogens, even that is not a good thing. So don't you think there requires a balance on this also?
See, Mr. Srinivasan, we do need a lot of other departments to work in cohesion with the health department. But what has happened since beginning, that when the pandemic was declared, the authoritarian approach was given to Home Ministry and ICMR. ICMR is a research body. It's not a public health body. And public health bodies like Centers for Disease Control or NCDC was totally sidelined. Health Ministry was totally sidelined. You go to the national task forces, state task forces. Pediatric surgeon is the head of the COVID task force. Now, if you put people like this, then because you want to honor somebody, you compromise your entire system. Secondly, if suppose IITian or somebody has a good idea, let us discuss threadbare. Let us not get into any kind of, because I was discussing with some of those IIT people, they were talking about golden curve, where curve will go like this. But I asked, how many cities? 4 cities. Or how many states? Only 4 cities. Based on 4 cities, he is projecting for whole country. I think that is wrong. Secondly, we undermine our capacity. Now, I will give an example of vaccination program. It is laudable. All over the world, it is lauded. But if you look at it in the beginning, we have 12,50,000 MBBS doctors. We have 4.5 lakh postgraduate doctors. Total 17 lakh doctors. Imagine how many doctors were involved in vaccination. Hardly any. So what you are doing, reinventing the wheel. You are doing a mock strategy, how to vaccinate, how to fill up the syringe, how to take out the air, and then where is the deltoid muscle, and you are training a whole sort of new people. You are not using existing facilities like PHC, cottage hospital, but at the same time you are doing vaccination in Dharamshala, Gaushala. Now, I think something which was rubbish happening. And we need to understand that our capacity building has to be done by those who are having capacity. And if they are sidelined since beginning, how will you do capacity building? And therefore, we lost initially, if you see, up to 23% of doses were lost in just refilling. As a doctor for 41 years now, I have not seen any kind of wastage in my clinic. How can a vaccine be wasted by just it went into air like this? How you cannot do that? If you should have a strategy of if the vial is containing 10 doses, when 10 people come, then you open the dose. There's no point in opening dose for 2 people and 8 doses are wasted. So all these strategies could have been well done with the public health people at helm of the affair. So basically, okay, we should project, we should have some kind of vision, view what can happen, and therefore we should have a pandemic preparedness, not for disease A or B or C. Any kind of pandemic come or any kind of bigger strategy, like we have a national disaster management team. So a cyclone come, there is a team which rushed to that place. We have hardly seen any kind of deaths in Odisha now. So that should be a focus. That one world, one health, one hope. And if we do that, then whether today, tomorrow, monkeypox comes, anything comes, again monkeypox, they're saying we should have a thermal scanner at the airport. Nonsense. Have you caught one single case of COVID by thermal scanner? Why you put machinery there which is not going to be useful at all? You look at monkeypox will be pox marks, some kind of lesion on the face. So examine palms and soles, examine extremities, ask them to show gland if there is a gland or not. You cannot use same old strategy, and then you put countries one by one. 30 countries is at risk. So people coming from those 30 countries. These 30 countries diagnosed. There may be 100 countries which are not diagnosed. So that kind of knee-jerkism, putting one by one country, and then they say India has put Bangladesh into this risky country. Next day, Bangladesh protested. India had to remove Bangladesh from there. So we should not get into this kind of knee-jerkism or putting one country down with another country, one state down with another state. Let the state be run by any government, any party. You see, this is a nation, state, district. Put everybody which are at the helm of the affair, which are having some kind of background, and see that it will be run. If something is wrong, you change it immediately. You don't wait for heavens to fall there. So I think if we manage that way, I don't think there will be a problem. We have managed well. Sometimes we always say God is with us, God is with us. And sometimes we also say that even organism has to survive. Organism doesn't want to finish human race. If they finish, their whole purpose will be defeated. So organism also have some kind of sanity. We have not seen any organism pan world and pan 100 years surviving more than 2.5 years, 3 years, creating havoc. So 2.5 years are over. It will not create havoc. It will be having endemicity. Even if it is there, we will be able to manage. Let us not close down. Let us not affect livelihood. It has been enough harm is done. Collateral damage has been done. HIV cases, people did not get diagnosed, get treatment. Tuberculosis, lot of people died of tuberculosis waiting for treatment. We were so inhuman that deliveries, even I had my both daughters being delivered in that same period. As a doctor, I had to rush pillar to post to get PCR done, get the report. Till that time, they will not take her into delivery room. This is nonsense. You did allow people to attend the funerals of their relatives and near ones by a nonsense agency like WHO, which said that aerosol is not the solution, is not causing the infection, surface is causing infection. All newspaper industry was closed for 1.5 years. No newspaper, no magazine. People thought they will pick up COVID infection from newspapers. So I think we made a lot of mistakes. And let us learn from those mistakes and let us understand which authority to follow, how to correct ourselves, how to apply our mind what there with a new disease scenario. And if that is done, I think that's what we and Dr. Sunila Garg exist, which is called Organized Medicine Academic Guild, Federation of 15 different postgraduate medical doctors association. And we would like to support, our nation, our people. If somebody is going to die, suffer, they are our relatives and dear ones. Why will not support them? So I think that should be the scenario.
Right. Thank you. Dr. Reddy, Dr. Girada raised a lot of important issues. The life after COVID now is pretty different from what was earlier. We were in complete ignorance. Some of us didn't know even how to wash our hands properly. So the entire washing our hands to, social distancing, a lot of new terms which we learned. But from what I heard from you, from Dr. Gilada, there is a lot of things which probably we are already learned, but not sure whether it is being learned to an extent that it is being implemented, and be seen that we don't make the same mistakes again. So as an infection specialist, what would your response? What should now we be doing? We have a lot of information now, which wasn't there pre-pandemic. Are we moving in the right direction?
All those habits, what you talked about, they had to come through the behavioral change, right? Behavioral change usually takes a generation. It doesn't happen in a day or in a year also. It takes over a period of time. You talked about very important issue, that is hand hygiene. Even after so many years or so many decades of training and retraining the doctors and the nurses within the healthcare system itself, even today, the compliance rates are paltry. If you actually take out the COVID-19 scenario, prior to COVID-19 scenario, and now when the risk perception is already down, you look at the compliance rates. Among the doctors, it never reaches 50%. Among the nurses and probably other healthcare workers, probably, at best, we will have 60-70%. Of course, there are multiple contributing factors for non-compliance. It is availability of your running water, having wash basins, having, your hand hygiene products like, the sanitizers, or we call it as hand rubs, alcohol hand rubs, etc., etc. But, even after having them, if there is no kind of behavioral perception that it is required, the people will try to, evade this rule, which is going to be set by any other institution. Certainly, we are in the right direction, but the messaging, whatever we are doing, it had to continue because, as I have mentioned earlier, it definitely requires, a long-term effort in order to bring a change in the behavior of the people in terms of, one or the other practice, right? Hand hygiene is a practice, right? So it takes a longer time, but, COVID has given us a golden opportunity to bring in certain elements which are very important in terms of the hygiene, which is, 80% of cause of actually our, all the infectious diseases. Either it is within the community or within the hospitals also. We give a lot of importance in infection prevention and control to hand hygiene, which can actually reduce the burden of healthcare associated infection by at least half. 50%, we can straight away actually cut off the healthcare associated infections if we have got the right kind of compliance with the hand hygiene. So I think, at both and at community level too, a lot of infectious diseases can be prevented if the people are going to continue with the practice, what they have learned during this period. Same thing with social distancing. But in a country like ours, of course, it is not always possible to maintain that distance. You go to the Western societies, even otherwise also the people keep a distance, right? Because there is a possibility there to do that. But probably in Indian scenario, it may not be possible. But I think, these practices and, these kind of changes which have happened during this period, if we are going to carry forward, definitely it is going to do a lot of good. Coming back to, what Dr. Gilada has said, yes, any pandemic or any emergency definitely creates initially the confusion, right? It is, I think, especially if we are dealing with a once in a century kind of event like COVID-19, there would be missteps. There would be definitely, a kind of chaos. I think, as a world and as India as a country, I think, despite of all those missteps and also all that chaos and confusion, I think, we have dealt with that, in my opinion, I think broadly very well. Yes, we had to take a lot of lessons from all those missteps and also all that chaos which we have initially created. We need to put the right kind of people at the right place, right? Like, very popularly, a saying goes, that donkey had to do donkey's job and dog had to do dog's job, right? If we are going to mix them, definitely their role, you are not going to get anything. If a donkey is going to keep barking, it is not the right way actually. So I think, putting the right kind of people at the right places is part and parcel.
No. So sorry, I'm interjecting you. Dr. Gilada raised an important point while talking about ICMR and talking about other institutions where a bit of heavy-handedness was attempted initially, and some of us are even surprised that these kind of communications are coming from areas which is not their core competence.
I agree.
Yeah.
I totally agree with that. I think,
has his attitude changed now? Do you think after, second and third wave now we have wizened not to do that? Or
I think to some extent, yes. I think, the government understood, the people understood actually, who had to be at what place in order to deal with these kind of emergencies, if they are going to happen. I think, at least I think there is a sense of it.
Right.
I'm sure whenever it is going to happen, I think we will be in a better situation in terms of placing the right kind of people in right position to deal with the situation.
Right. I'll come discuss more about behavioral things with Dr. Garg. I think it's an interesting issue. But before that, I want to come to Dr. Anusha Rohit. What should be the clinical protocol? Because end of the day, if these are mild infections and people are going to stay at home and kind of self-isolate, or so that they come out of it on their own, if those are the issues, unless it becomes too severe or they have a lot of comorbidity, admission becomes important, those kind of issues. What should be what should they be doing now? Earlier we were all advised do immunity boosting, all kinds of vitamins are prescribed, people are going after vitamin D, vitamin C, vitamin A, this, that, whole lot of thing happened. What should they be doing now? What would be your advice to anyone, suppose, who gets a fever?
Thank you again. So I think the one single most important measure that you can say from infection control in any scenario is hand hygiene or hand washing. And I think, this does not make, a COVID pandemic does not make it any different, even though it is a respiratory virus that does spread through respiratory droplets. Many a times the spread is also through your hands that constantly keep touching the face. And if you say that, we've learned our lesson, I think, however strict the measures were initially, when we knew very little about this virus and how it spread, even then we did not think much about hand hygiene, because we are talking about a single important measure that came out in the 1850s in Austria by the father of hand hygiene, called Dr. Semmelweis. Now, just to give a little perspective to everyone who's listening, Professor Semmelweis was working in a hospital in Austria, and he found that the death rate of people with puerperal sepsis, that is, people who died after childbirth, was much higher when they were in the hospital than those by the midwives. And he found that it was the lack of hand hygiene or hand washing that was a single most measure, that important measure that needed to be put in place. And he put that in place and actually brought down the rates of mortality of group B streptococcus causing puerperal sepsis. Now, 150 years later, we've still not learned our lesson, have we? We're still talking about the same tenets that need to be spoken about. We're still, emphasizing on the need for hand hygiene and hand washing constantly, even in the healthcare setup, where we are constantly facing small mini outbreaks all the time. So considering all of these, I think, we still have to remember that hand hygiene is one of the most important measure. The second important measure is that we realized, as far as COVID-19 is concerned, is the need for importance on ventilation. And ventilation becomes very important, especially because COVID spreads in closed, crowded surroundings. And anywhere where you have this kind of a surrounding, you have to think of how to get a little bit of air into that place so that there is ventilation. Of course, it's very difficult in very hot places, especially in summer in a country, tropical country like India, which is where we have to start thinking of innovative ways to look at at reducing spread through improved ventilation. So a little thought process into ventilation pays a great deal on a long-term basis for all of this. And, when the other eminent speakers were talking about, building capacity and, surge capacity for future pandemics that may be there, we need to also understand that we have to have plans in place for possible, measures that may be need to take that we may need to take, considering that we have a lot of infectious diseases still around the corner. It may not be COVID-19, it may be something else, but the tenets of infectious diseases and microorganisms remain the same. The kind of isolation may just differ from contact to respiratory to droplet to airborne, but essentially the basic need for all of us to understand is hand hygiene, masking in crowded places at least, or closed unventilated places. But in open spaces, the risk of transmission is rather low, unless there is extreme amount of crowding. So what we need to do going forward is, I think about ventilation as an important measure, and not forget that the 150-year-old lesson that Semmelweis taught us. The poor man actually was then put into a mental asylum because he was so obsessed about his theory of hand hygiene. And that, I think, we haven't yet learned our lesson beyond the last 150 years. So I still think we should...
So the clinical protocol, if you could include that, or any other doctor would like to take that.
I probably, if it is okay, I will go.
Please go ahead.
Sure.
Yeah. Sure. I think, by now we have a very good clinical understanding of the disease. I think all what we had to do is more or less clear. And some of the very good antivirals stepping into the system, like Paxlovid, et cetera, has definitely made our life much easier in the clinical settings. I think, whatever is required actually to manage a moderate to severe disease. Mild, I am not even talking about, because currently the mild is managed sitting at home and taking a little rest and, et cetera. I think, we have learned enough actually to deal with the moderate to severe disease. The current protocols which are available, they are really clear. Initially, yes, it was all, again, chaos. We have gone for every kind of possible medicine, which is available. Every kind of experiment was being done. I think all that experimentation stage is over. More or less, we are very, very clear about the management of the disease, both in terms of if you're severe and also the moderate disease. So going ahead, I don't think it is a big problem. I don't want to go into the detail of what is the protocol, how do you manage what kind of medicines, et cetera. They are not required for the general public. General public also need to understand that only to some extent they need to understand the overall disease management. Rest, I think they should put their health and the life into the hands of actually those who are capable. That is the doctors. They had to have a trust in them, and they had to give a free hand to manage their disease, rather than trying to come up with all kinds of things. During the COVID period, a lot of calls come. Doctor, I have this. Can I take Remdesivir? What do you answer?
Yeah.
There is nothing to answer. So I think infodemic is also not right. Means knowing too much and having inability to convert that knowledge into action. It is not going to do any good. It is going to do only harm, because the doctors would not be able to help you, because you come with some information which is not required for the doctor actually to put the right kind of diagnosis and give optimal kind of treatment, which is required to make you, go on with your life.
Yeah. So it's just one query, you said mild management requires, that's going to the maximum number of cases, I suppose. It just requires rest or something else they need to take care of, because that's going to the largest number, I suppose.
Absolutely. Asymptomatic and mild are 90+%, right? There are very few cases, especially now, I think, it is below 1%, those who require, kind of hospitalization. The rest of the people would require actually to stay at home, keep a watch on their symptoms in terms of actually their oxygen levels or, any other symptoms, and take abundance of rest and take, kind of normal course of things, which require, a good sleep, a healthy kind of food, that is protein enriched food, and take rest. And I think, in most cases, within 3 days, most of the people are coming out. I had a recent attack of Omicron about some time back.
No.
It is just 2 days rest and, it is over. So in most of the cases, it is like that. So the people should know what kind of symptoms they need to watch for. And whenever actually there is a threshold which is happening in terms of, your oxygen levels and other things, you need to approach the medical doctors so that they can help you out.
Here is another question I want to ask. I don't know who would like to take it. Dr. Gilada, you would like to take it, or I would pose a question to you, but anybody else is welcome on this. See, the thing is, we know about the vaccines, and largely majority of vaccines are basically adenovirus based. And, of course, we made our own killed virus, the first one. But shouldn't we going for the next generation of mRNA vaccines? Are there any progress in that, or are we still at a learning stage on that?
Mr. Srinivasan, let us speak about vaccine in a comparison what is done in this third country. In Malaysia, they compared 3 vaccines. AstraZeneca, that is our Covishield here, Pfizer mRNA, and Sinovac from China. And they looked at the infections happening after vaccination and how many people died, which is called breakthrough infection and death through breakthrough infection. What they found, adjusted with the population, how many people were given which vaccine. If there was a 1 death from AstraZeneca, there were 2.5 deaths from mRNA and 9.5 deaths from Sinovac. And this is done in 4th country. It is not done in the country of origin, so that they will speak that our vaccine is better than other. So these deaths happened from AstraZeneca, which is Covishield in India, and fortunately 90% people got Covishield. Secondly, mRNA, wherever mRNA is given, after 3 to 4 months, the antibody levels went down. So they were talking about 3rd dose, 4th dose. In India, we put 9 months. We were saying that we make it 6 months because we have plenty of vaccine available, and 6 month gap is good enough. Lastly, best is natural infection. But we don't want people to get immunity through that best way. But fortunately or unfortunately, 85%, 90% people in India, they got natural infection. Most of them may not know. So if you look at, I'm doing antibody test in my clinic, I find 9 out of 10 people are antibody positive. I'm talking about antibodies which are from natural infection, not from vaccine.
Right. Yeah.
So a lot of us got hybrid immunity. And natural immunity is better. Hybrid immunity is much better. And vaccine immunity is less than all other two. So basically, let us not say which vaccine is better, which we should have had this or not. However, it is important that we should have a mix and match system where there are 2 studies which shows. One is from Christian Medical College, Vellore, which shows that the vaccine, if Covishield is given after Covaxin, it gives 9 to 10 times more antibodies. But the other way, it is not so. So Covaxin is not given after Covishield. And the second study, after which the DCGI has given the approval to Corbevax, that if Corbevax is given to any of those people who received either Covaxin or Covishield, that works better than the homologous vaccine. So if we have all these vaccines in India, and our mRNA platform is also there, one is done in Genova and one is done by Hyderabad company. So I think we have mRNA also. So we should study that but we cannot say that mRNA would be better than other vaccines.
Definitely,
Yeah,
I'd like to
okay.
add one more. I'd like to add one more thing also, that you see, irrespective of this, the message which has to go is that the vaccines, will not prevent you from getting the infection. That is one thing. They will only prevent you from getting the severe infections, hospitalizations, and death. So this is the message what people, because people normally become lax after taking the vaccination. And that's how, majority of the infections, that is the breakthrough infections are happening, because people stop following the COVID appropriate behavior also. If you will remember that when we started the vaccination program on 16th of January, so last year, so what we found was that basically at that time only mask was our most important social vaccine. So that is one thing which has to go hand in hand. We cannot say that we are vaccinated, so we forget everything. So that is something which we need to reiterate again and again, that as of now, whichever vaccines are available, they will not protect you. They should not give you false sense of security that they are going to prevent you from acquisition of infection. They are going to prevent you from getting the severe infections and all that. But particularly some people are more vulnerable. We have got 9% of our, 8.5 to 9% people are there who are elderly population, and they are the ones who are suffering from comorbidities and all. That's where we need to focus, apart from our 2 doses of vaccine, precautionary dose as well. So this is where the government of India also started this Ghar Ghar Dastak Abhiyan, because let me tell you also that we discussed about the vaccination strategy. We utilized all our 29,000 cold chain points that is there, which have been created under Even platform that is there. But apart from that, because India is so vast, so diverse, and our population is very diverse, so we found that elderlies were not coming or pregnant women were not coming. So that is where, we had to create, facilities outside, which will, one size does not fit all. And that's what we did in cases of polio also, which we are doing still now. Another thing which you have to keep in mind is that who are going to be very important messengers of change with regard to, control of pandemics is also we discussed. We have been very successful in some of the initiatives like polio elimination, where we created Polio Unmoolan Sena, or Say No to Crackers by involving children. So we need to, kind of have a faith, through our school-based strategies. We can focus upon not only upon, taking of the immunization part, from the family's perspective, but also we need to look at, when we talked about the behavioral change, hand washing and all, something, it is not we are talking today. Our average Indian child, in infancy gets 4 to 6 episodes of diarrhea. That's where we talk about our whole, IMNCA, integrated management of neonatal and childhood illnesses, talks about, hand hygiene in a big way, respiratory etiquettes in a big way. So that's where we need to, kind of, if we tell our, woman to breastfeed a child, again, we are stressing on hand washing at every stage, but we presume that that is inculcated. But some of these messages have got to be reiterated using 360-degree approach, whether we use our digital media. And I say that wherever the organization is there, they must bring out a small circular that, have you hand washed your hands? Please hand wash regularly. Make use of technology with regard to whether we talk of, every message related to pandemic, whether it is regard to vaccination, whether it is regard to, home management. When we talked about home management, it is also, to be in touch with the provider. Last minute, we cannot say that the person has been, in home, he's elderly, he has suddenly deteriorated. So we have to be very much prepared. And that's how, COVID has humbled all of us. Number one. Number two is that we have learned a lot of things. We are still learning a lot of things. So this is where it is important. And that's where, and Dr. Gilada keep talking about, about this whole aspect of, kind of, every day there is a new learning. But then, now for a change, now National Institute of Disaster Management, National Centers for Disease Control, and CDC India, we are, because this is also an offshoot of CDC Atlanta, we have come together along with OMAG. That's where, the common webinars are being launched about how did we go along with the pandemic. And we all have been party to, delivering different webinars as well onto, so right from the beginning journey, because, when we said that ICMR was involved in all that, even government was struggling hard, but that is where, the public health perspective comes in. And now we have started talking of epidemiology intelligence services, which is already a program which is being run by NCDC. Every district should have a epidemiology intelligence officer so that forecasting can be done with regard to not only, where pandemic is one time this thing phenomena, but we are talking of emergence of, outbreaks of different diseases. So that's where our IDSP platform, which is very strong, has to be really analyzed, has to see that how the forecasting of different diseases can be done. Thank you.
I would like to just add one comment. The anti-vaxxer should be stopped totally, and any kind of anti-vaxxer movement should be nipped in the bud. Because it is okay if you don't want to take vaccine, fine. Don't propagate something. That kind of thing, you create awareness, and one of the anti-vaxxers comes and says that despite vaccination somebody died, and that is a headline everywhere. That creates a lot of panic in people, and people don't want to take vaccine. So we need to look at.
I agree with you, but Dr. Gilla, the point is why what Dr. Garg is saying is very important, and what you're saying is also important. But how do you communicate such a complex message? Hand washing sounds very simple. It's easy to say wear a mask, but then exactly the question: somebody who has got double dosed and still gets infection, he'll come back to you and say, "What's the point? You asking me to mask again?" This includes doctors also, as I think somebody pointed out here, that even they resist wearing mask. So the public communication, I agree, is a tough thing.
Dr. Sunil said very clearly that vaccine should be propagated for preventing severe illness, hospitalization, and death. Infection prevention, yes, 60%, 70%, 80%, depending on what variant, what subvariant is prevalent at that time. But whichever variant comes, whether it's Omicron, BA.1 or BA.4 or 5, at least severe infection, hospitalization, and deaths are prevented. And that is what, so, there are different vaccines, but the purpose of the vaccination in COVID is to prevent death and hospitalization. Like polio and other vaccines, prevention of infection. Smallpox, prevention of infection. Here also, prevention of infection is there, but it is the fourth level, not first level.
And another thing I like to say is that under COVAX strategy, when we say that different vaccines are being wasted, across the world, we will say that only 56% of the people have received vaccination. We are only protected when everybody is protected. So why the question of wastage comes in? That's where we need to be very proactive, and we have to be liberal. You see, when we talk of one world, one health, this is where we have to see that every country is able to have, it's a question of equity and equality also. So we are only protected when our neighbors are protected.
I agree.
Absolutely.
See,
I think, Mr. Srinivasan, I would like to make one point here. I think, I totally agree with
just
Dr.
if you, I mean, Dr. Reddy, please give your this thing. Just include my question as well in that. That would be nice. You see, India's, the vaccination is about 65% fully vaccinated, eligible, which means that even now 25-30% people are still not vaccinated fully. That's one data. Second is 68 countries still have not got 40% vaccine coverage.
Yes.
I mean, consider these two issues. Please answer. Yeah.
Absolutely. I think, I think we were having the same wavelength, in terms, I was just coming to that point only. The vaccine equity is the biggest thing, what we need to immediately address. When we are talking about the boosters, etc., yes, boosters are required. Boosters are required. We need to again prioritize who need to get the boosters. Those probably, as Dr. Gilada has very clearly mentioned, there is no good thing than having hybrid immunity. And most of our population today, especially those who got the natural infection and also at least 1 or 2 doses of vaccine, they're already protected. We don't know, how long, that immunity is going to stay. That is a very different question. There is no unequivocal answer to that. But, looking at the world, I think, I totally go with Dr. Garg and Dr. Gilada. We need to focus on the vaccine equity. If somewhere there is going to be infection, definitely that is going to be a kind of a breeding ground to get the newer variants. That is what happened. How did actually Omicron come into the picture? It came from an immunocompromised patient who did not actually had the access to the vaccine in South Africa. So while actually doing our planning in our country, while we are talking about our boosting the population, etc., while we are going to allocate the optimal number of vaccines to boost the vulnerable population, we also need to think about those deprived world who can actually also be a problem for us, if not tomorrow, after some time. So I think, India is in the best position in terms of, its vaccine manufacturing capacity. Today, as I understand, most of the vaccine manufacturers have scaled down their manufacturing because there is no demand for that, right? Because the government is not buying, the people are not ready actually to take those vaccines, etc., etc. I think, this is the time for India to provide the leadership for the world, not only, by saying X, Y, Z in terms of actually communicating, but also in real actions. We need to get into a kind of driving role for the COVAX also. We need to involve all the manufacturing capacities within our India in order to provide the world with the necessary vaccines so that, we see a phenomenal increase in terms of those people and populations, who are going to be vaccinated. I think, that is absolutely important for us. While looking in, we also need to look out so that, the neighbor is protected. Only when our neighbor is protected, we are going to be, safe. I think this is the point I wanted to make. And when you are talking about, India's numbers, I think, whatever is done in terms of 65% or 68, we don't have exact data, but I think, that is good enough. Majority of the population is already covered. Those who are actually not yet vaccinated, we need to continue to messaging into the population so that, they are going to get vaccinated and, protect themselves from severe infection, which can lead into fatality. I think, that's a very important communication which keeps on, which had to, go on for some more time before all those people, who are left out from this national campaign are going to be brought into that vaccinated pool. That is certainly there. And as far as younger population is concerned, we all know that children can actually deal with this virus in a better way than the adult population. I think, I made actually the opening remarks saying that population defenses against new variants and also the existing variants is strengthening, already strengthened, and it will continue to strengthen as immunity is going to increase through the vaccination and also the natural infection, like possibly other human coronaviruses. Children probably would very likely be exposed to COVID-19 during the childhood, those who are now below 16, and probably the future generations are likely to, progressively be more protected with this combination of vaccine and also the infection. So I think, on one side, definitely we need to probably look at vaccination, but I think, we should not be overdoing our vaccination by boosting everybody and by giving, to every possible child the vaccine. I think, that is what is my view. Definitely, I think, the children today.
So here is a question, maybe Dr. Rohit would like to answer. You see, the thing is, vaccination for children is a very crucial one because schools have reopened, they have to go, they have to feel confident. Government has already opened for those under 12. The emergency, this thing has been allowed under that window. But in the US, vaccination for 5+ has been made mandatory. What should be our approach there? Should it be mandatory for children, or it should continue the way it is right now? And what about children below 5? The two questions.
So again, I think we have to understand that India's social structure is very different from that of Western countries. Most people have elders in the or other, vulnerable population in the house, with the children also being there. So I would think that we need to be sure about what we're doing as far as vulnerable population, also in terms of our pediatric populations, who may be the way of the virus actually keeping alive in the community for spread. So considering that, I would think that we need to vaccinate populations, especially school-going population. And the esteemed panel has multiple times said that vaccination is something that reduces in only the chance of morbidity and mortality, that is severe disease and death, but not really infection. And that actually answers the question that you say, what if somebody comes back to ask you the question? That he comes back is because of the fact that he can come back to ask you that question of what is the use of vaccination. So I would think that the emphasis has to be on good public health strategies that are there, because now this has moved from the hospitals towards a public health approach that we need to have towards larger picture of the pandemic and the virus spread in the community. And we need to understand that vaccination in the pediatric population is actually more easier than in the adult population. Most of us think that adults do not require vaccination, which is very, very untrue. But even adults require the flu vaccination on a regular basis. Quite a few vaccinations are required for adults as well. So, with that, we have a strong forum like the IAP, that is the Indian Association of Pediatrics, that is, doing yeoman service as far as, vaccination for pediatric population is concerned. And it is always easier to address a group like the IAP, because when there is a forum and when there is a concerted group of people who are making decisions, I think it would be better. So, the age group for the vaccination, the clearance as far as our DCGI and all of these are concerned, I think is being closely worked out by the different groups of physicians working together. And to re-emphasize on the fact that vaccination is important, and we cannot in any way, say that it is of less importance. With that, I'd like to close off.
Yeah. So
I'd like to have one more. I'd like to have one more comment.
Yeah, sure. Please go on.
Yeah, because quickly, as National President IAPSM, we have already come out with a guideline of school opening guidelines. Number one, there is no compromise between the vaccination and opening of schools. India was only amongst the 5 countries where the schools were closed. We have gone back by 4 to 5 years of development. And you see, my husband being a pediatrician, I could see that children are, they have not learned to speak. The ones who were to act, very fast, they're only signing because they've never heard their parents talk. Both working parents, they've not heard the teacher speak. And this is where our examinations also showed recently that the children cannot cope up with the exams as well. So this is where we need to think about the holistic development. Vaccination will go at its own pace, but it should not create another thing. That the messaging has to be very clear. We need to focus on teachers. We need to focus on all the school authorities. We need to focus on children. But then another thing is that we need to also see that children will catch infection fast. They will recover also fast. And as soon as it comes, at least 5 to 12 years, one can start. The vaccination has been already approved. But thing has to be, the communication strategy should be very, very clear that vaccine will not definitely help you in compromising with the COVID appropriate behavior. That is. Thank you.
Yeah. So quickly, Dr. Girila, is a question for you. I mean, this has come from an audience. There's still some confusion. See, the thing here is we don't have enough data on immunity, how much immunity is there. But it is necessary. All the doctors agree, and everybody is saying that, vaccination is necessary, 2 doses. What about booster? Is there a mixed messaging there? What about booster? Who should go?
Basically, as we were discussing all along this program, immunity has mainly come from natural infection, and most of us have been naturally infected. Secondly, we have taken one dose, second dose. Booster is required for those people which are with morbidity, whether they are above 60 or below 60. And currently, we should speed up the vaccination of those which are not vaccinated. So you were asking, you're telling that 64% of the population is fully vaccinated, but 20% of the population has not received a single dose. That is below 11 population. So if we take out that 20%, then we have done fantastic vaccination, at least single dose and double dose also. And if we see the current speed of vaccination, which is 15 lakh a day in the country, which is only 6% of our top capacity, we could vaccinate 2.5 crore every day. So we are doing only 15 lakh, despite vaccine available. So at a time when vaccine was stock out everywhere, people going for this week, there is no vaccine. Now plenty of vaccine, but people are not taking. So I think we should speed up that vaccination, which have not been vaccinated. If people are talking about school, vaccination is important from 2 points of view. One is preventing them, but secondly also a boost up mechanism in the mind that you have been vaccinated, you can go to school. And thirdly, even if some child comes positive, there is no need to close the school, and that is happening as a knee-jerkism in most places. By the way, the child is infected either by the parents or the teachers. So why close the school? Because one child or two children are found positive. Lastly, you are also telling about vaccine equity. India has been a great example of not only vaccine equity, but also treatment equity, medicine equity. All over the world, 85% of the people are taking HIV medicine from India. And it's not happened in 2 years, last 10 years. So this is a great example that it's important to make a molecule, but it is more important to copy that molecule and make it available to everybody at affordable cost. Somebody should understand that anything which is costing $100, India can provide that in less than $1, at less than 1% of cost with 100% bioequivalence. And therefore, vaccine, medicine, treatment equity, only India can be a classical example. Western world is useless. They stockpiled 300%, 400% vaccine, and now they expired, but they did not donate to poor countries because they thought Africa doesn't deserve mRNA. They deserve something from India. So that is.
Sorry, I'm interjecting. We're really running out of time. Just 2 minutes left in closure. I would request all of you to go one by one, take 30, 40 seconds each and say, when they hear such news stories now in the media saying that, is it Omicron, another wave coming, the daily cases are going up, when they're listening and hearing those kind of messages from media, what should be their response? All of you can quickly finish that we'll conclude with that. Dr. Gilla, you can go first.
Basically, we should tell people that if there's no infection, no bacteria, no virus, no fungi, and no diseases, all of us will survive for 110, 120, 140 years. That is not going to happen. The current era is of viral infections because we have enough antibiotic, enough antibacterial, antifungal and antiparasitic. But adequate antivirals are not there. So whatever new infections will come, they will be mostly viral. And you expect that diseases will keep on coming and we need to keep on fighting. So it is God proposes, man disposes, man proposes, God disposes, that in a phenomena will go on. Let us not be worried about Omicron, B1, BA.4 or 5. Let it be any kind of wave. That wave is not going to stop us. Is once in a blue moon it happened. Second wave that devastated, but this is not going to happen again. So I think we should not be afraid at all. We should not have any knee-jerkism. We should carry on our livelihood, socialization.
Thank you.
Yeah, that's
understood. Dr. Garg, quickly, 30 seconds.
Yeah, life and livelihood have to go together. We should not panic. We should be watchful about the situation. The communities need to be well aware of. So this is where the role of digital media, print media and all is there. And we need to have a 360-degree approach in addressing the pandemic, including, the capacity building of the system. Please make use of the telemedicine. That is very, very important. If anybody has got any doubt, please don't rely on, information from the friends and all. Go to the truthful sources of information, that is Ministry of Health and Welfare or NCDC website, or when we talk of ICMR website, you get the correct picture. So do not rely on false information.
Thank you. Dr. Rohit.
My take would be, remember, simple steps help us get over complicated problems also. It is important to wash hands, to remember how you have to have an etiquette in a crowded place, what is the social etiquette in a place that is poorly ventilated. And most of all, like everyone has been reiterating again and again, not to panic, but be watchful from authentic sources for information.
Yeah. Final views from you, Dr. Reddy. We're really running out of time.
Yeah, sooner than later, like any other pandemic, this also would end, and end would be through endemicity. Definitely, we are going to see the outbreaks. Probably it will become seasonal over a period of time. So let us learn to live with this rather than getting every time you hear about actually some surge, some outbreak, getting panicked and, making your life cumbersome. Let us leave that. Already we are living in a very stressful world. Let us not take unnecessary stress out of all this news which is going to come around in the newspapers. Just live your life calmly, quietly, learn to live with COVID or any other viruses like, what humanity has seen for hundreds of or thousands of years. That is what.
Well said. Well said. We conclude our webinar with this. Thank you all for joining this webinar and giving us so much information. Thank you very much. Bye. Good night.
Good night.
Right.